Okay, very excited to be here, and we're going to talk about something that you all know very well, which is the unmet needs for these patients in terms of limitations of diagnosis and also the conventional therapies that we have. Okay, so we're back to Mark, and here are the unmet needs. So now he has a diagnosis, and we understand the pathophysiology, but here he still sits. It took months to get a diagnosis, months that he didn't know what was wrong, a lot of stress and anxiety about the rash and the itch that would not go away. And he's not found a treatment that really controls the disease. One of the treatments he tried didn't do anything for the itch. The other one gave side effects, and now struggling to find something else that he can use to treat his disease while he's taking his other medications. Okay, so we all know this in our clinical practice that there's multiple factors that complicate the diagnosis of bullous pemphigoid and can lead to delays in treatment. And I think here at the very center is the delay in treatment, right? 6 months mean diagnostic delay that can range up to 6 years for these patients. And so again, multiple factors contributing, and we're going to go through them one by one. The first is the diverse clinical presentations. So we know when we see blisters, we're thinking about bullous pemphigoid, but now we understand better there's a wide spectrum of inflammatory lesions with or without blistering, and that these non-bullous or atypical presentations can certainly lead to a delay in the diagnosis for these patients. The second one is the differential diagnosis. And so again, when there's blisters present, we're already in the category, usually our mind, of autoimmune blistering disorders, but there can be overlap in several of these disorders, like linear IgA bullous dermatosis or pemphigus. But then when we come to non-autoimmune, say, for example, conditions that can look very similar, bullous lupus, which would still have blisters, but many other dermatitis that don't have blisters. So allergic contact dermatitis, atopic or nummular dermatitis, hypersensitivity drug reactions, urticaria reactions. So a lot of things that would be in our differential diagnosis, which again, just we need to be thinking about it. Otherwise, we would have a delay in our diagnosis. Next is the advanced patient age. So we all know that many of these patients are elderly. They have serious chronic comorbidities that might get in the way of the diagnosis, but especially the treatment. Many of them have restricted mobility or cognitive decline that affects their access to healthcare. And then again, we all know a lot of us have long wait times. So just getting in to see the dermatologist, coupled with maybe they have to have a family member to bring them, right? The advanced patient age can certainly lead to a delay in access or delay in diagnosis. And then finally, the fact that this is an orphan disease. So it's fairly rare, especially non-bullous presentations might not be recognized as outside of dermatology and likely underdiagnosed by non-dermatologists, but also by dermatologists themselves. And then finally, just understanding that many of these patients don't have safe and effective treatment options. So again, we know that what we want is a timely diagnosis. And the reason we want that is for optimal management to minimize these associated complications. And the really one that's most feared is infection. And so these are just some slides again that show that BP patients are 2 times as likely to develop serious infections as controls, and that many of these patients die due to infection. Here you can see a wide range, but that's pretty significant mortality directly related to infection. Systemic steroids here at the bottom, you see, was the strongest risk factor and doubled the risk for serious infections. And really, when we look at our current guidelines, unfortunately, systemic steroids are where we typically start with treating this disorder. So the goal in patient management, this is kind of our wish list, right? As dermatologists for our patients, we want disease control. We want to manage signs and symptoms, reduce recurrence, control disease activity, and have sustained remission. That would be lovely. We want to prevent infection, lower mortality risk, and lower comorbidity concerns in these patients, limit treatment side effects and treatment-related morbidity, and then improve, finally, all of it, right, to improve our patients' quality of life. But we know there are challenges that exist to achieving our goals on the last slide. And that, again, is advanced patient age, which we already covered, high relapse and treatment discontinuation rates in these patients because we really just don't have great treatments at this moment. Presence of comorbidities and polypharmacy in this patient population is huge. And then the risk of adverse events with our broadly immunosuppressive drugs, which include, of course, systemic steroids. And so all of these things have been really associated with increased risk of adverse events. And so clearly an unmet need in these patient populations for safe and effective drugs. So as we all know right now, there are currently no FDA or EME approved therapies. And the off-label therapies that we have used for decades to manage this disease are associated with increased risk of adverse events. So targeted biologic treatments that really address the underlying inflammation are hopefully the future for treatment of this disease. Okay, thank you.